And so this week, we're going to be going into the more advanced functional diagnostics. And let me start with a really quick poll. So when you think about these advanced diagnostics, whether we're looking at stool tests, urinary tests, whatever it might be specifically related to hormones, do you feel that it's too much stuff? Like, do you feel overloaded with that or not? And so we're going to have a little quick poll that'll come up. All right. So those 4 questions. When reviewing complex lab panels, you most often feel, and just pick one choice, either confident and clear, confident but cautious, clear on some markers, uncertain on priorities, overwhelmed by competing abnormalities, or pressure to treat more than feels necessary. And just put that in, put your answer in that poll. And we'll use that as we're going along because we're going to be talking about some of the bigger, more well-known tests that really have a lot to do with making decisions about BHRT. Okay. And so got those results and we will go on. So this is looking at our course. We have 4 sessions, as we know. Last time we did our foundation. So we looked at the physiology. We looked at what the symptoms were that people were walking into our offices, to our clinics, to our centers with. What are they saying to us? And then what does that mean? And then what do we say back to them? Because a lot of times, as we know, these are women who have high demands on their life. And they're used to working at the top levels, and they want healthcare at the top levels, but they don't always want to take the time that they need to do that. So we talked about that last time. Today, we're going to delve a little deeper and really start looking at how we can assess if we're looking at some of the testing, the routine testing, and things don't look quite right, or there's something not quite, the way we think it should be, what might we look at and what might it mean when we get those results back. So that's our session today. So we've got some learning objectives because that's what this is all about, right? Number 1, we want to start differentiating between serum, urinary metabolites, and comprehensive stool testing for while we're doing a perimenopause assessment. When would you use them? When don't you use them or need them? Going that way. Then specifically for the estrogen metabolites, we're going to be looking at those patterns and what those specific patterns mean. The 2-hydroxy 4 and the 16-hydroxy pathways, what each one of those means. We're going to talk about when we actually need to do them. When is it really adding value beyond just a standard test? Because let's be honest, they cost a lot more than just getting a blood test. And then we're going to start looking at the gut as well, because one of the things that is so fascinating to me, and is a whole new avenue that's opening up, is how our gut really affects our hormonal status. And there's a really strong connection that we're going to be going into. And then finally, we'll look at some other markers, AMH and inhibin B, in our clinical decision making for that menopause timing. Okay. So per the NICE guidelines, nice, the diagnosis of perimenopause and menopause in women aged over 45 should be made on clinical grounds only, without routine testing. So what does that mean? That means if someone's walking into you and they have vasomotor issues, or really significant sleep issues, or weight, or a combination of all of the 3, what we need to start thinking is, if it walks like a duck and it quacks like a duck, let's not call it a zebra. Okay, let's think about, she most likely is going through perimenopause. And only when there are exceptions, and these are some of the exceptions where we want to do testing pretty routinely. So number 1 would be a POI workup, the premature ovarian insufficiency, women less than 40 who are presenting with amenorrhea or those symptoms that we were just talking about. If it's an early transition, it's not premature, they're over 40, but they've got those symptoms and they're not quite in the menopausal age either. And then finally, if it's really a complex case, you're doing everything that you know of, they're doing everything they should be, and they're still struggling, then you might want to look at, look a little bit deeper into some of the testing we're going to be talking about today. So let's talk about when we might do, all right, and what testing we might look at. So if someone is 40, less than 40 with amenorrhea, what kind of test do we order and what's the clinical rationale behind it? So if you remember from our first session with perimenopause, we look at the FSH times 2, 4 to 6 weeks apart. Because remember, if they're in perimenopause, those numbers can fluctuate wildly. So we want to make sure that we are getting them at 2 different times and that they are abnormal. We're going to also look at E2, AMH, anti-Mullerian hormone, TSH, and prolactin. These are all hormones that might be affecting whether or not a woman has a normal menses. And that is the POI workup. Requires confirmation, as I said, with that repeat testing. Okay. Now, if they are 40 to 45 with symptoms, okay, so they're not quite in that perimenopause age, menopausal age, what do we look at? Optional. Okay, so remember what we just said. If they, if they're in that age and they're close enough, 40 to 45 is a little early, but we may do that. And so you might want to confirm it for them. If they're struggling, they're concerned, and you want to know, you might want to do that. If there's an unclear menopausal status, again, so now we definitely want to do this, FSH, E2, and the AMH, okay? And this can guide contraceptive, contraceptive decisions and everything and planning. So, a woman comes to you and has been on an IUD for quite a while, or had a hysterectomy or something of that sort, and you really want to know what's going on. So you might want to do that as well. If you're monitoring HRT, so you're definitely going to look at their E2 if they're transdermal, progesterone if they're taking it orally, and you really just want to make sure that you're following the appropriate dosing and they're getting them in therapeutic levels. You're not diagnosing them, but you're just kind of following for the efficacy. Keep in mind, though, that we don't really want to just test and follow the test. So if they're on a level of estrogen and they feel great, and for whatever reason you happen to get one and maybe they're a little bit lower than you think they should be, then guess what? It's fine. If they feel great, then it's fine. All right. And then finally, unexplained symptoms. So now we're going to broaden that net a little bit. We're going to be looking at their CMP, their full thyroid panel, vitamin D, ferritin, is something else going on that we're not catching. Thyroid dysfunction, metabolic, nutritional deficiencies that could be mimicking menopause. So now let's get into these functional tests. We think about them as these specialty tests. And at first, I was kind of going the dried urine test for comprehensive hormones. We know who that is. We know what that is. There are other companies that do them. I love Dutch's training. They have so much out there for you. So if you're not familiar with them at all, that is definitely the place to start. So what we're looking at here is the hormone metabolism. Okay, so not just what the levels are, but also the pathways. As I mentioned before, the 2, the 4, and the 16 hydroxys and methoxys once they're methylated. We're looking at detoxification, methylation capacity in phase 2 detox. And then finally, we're looking at adrenal health. If you're looking at the complete test, you're going to see that 4-point diurnal cortisol curve as well as DHEA. And so in these high-powered women, that cortisol curve is critical to know. And sometimes that's the only thing that will convince them that, whoa, I need to slow down a little bit, because as we probably know, they should have that diurnal, that kick in the morning and then coming down so they can sleep at night. And so many of them have it almost completely flipped in the opposite direction. They're low in the morning, right? So they're waking up groggy, they're tired, they're exhausted, and they're elevated at night so they can't sleep. So it's only a lot of times when they see that, black and white in front of them, that they will actually say, whoa, I have got to stop what I'm doing. Okay. And they'll be there when, they'll be a little bit more ready to make those changes. So when will we use these? Well, here, like these, if there's an estrogen dominance symptoms despite having normal serum levels, okay? So they're having maybe breast tenderness or heavy clotty periods, whatever that might be, even though their serum is normal. So that could be, the estradiol levels could be normal, but they may be out of balance with their progesterone, okay? Or if they're having a poor response, you're giving them everything that you can think of, per their serum, but they're not responding the way that they should. They're not getting the symptomatic relief, and you don't know why. So you might want to look at a Dutch for that. And then finally, maybe they come into you and you know that they have MTHFR issues or some other kind of detoxification or methylation issue. You know they've got it. And so you want to see, what it actually looks like as far as their metabolites. We're going to look over those Dutches as well. And then we can go into the comprehensive stool test. And with this one, there are vastly more, and all of them are wonderful. So I'm not going to speak specifically to any one particular test, but we know that what they're looking at is the gut microbiome. Okay. And we're going to be talking about that connection between the microbiome and the hormone status. Okay. So we're looking at that gut hormone axis, beta glucuronidase activity, and we're going to go right into that. We'll look at dysbiosis and how that actually affects those beneficial and pathogenic bacteria will affect your hormonal status. And then finally, do they have inflammation? Are the levels like SIG-A and secretory IgA, calprotectin, do they have increased zonulin, things that would impact their hormonal status? So when might we use these? Well, again, if we're seeing estrogen dominance, but also associated with GI symptoms. So when they're coming in, they're complaining of, the hot flashes, but they're also bloated or they've got constipation, diarrhea, then you're starting to think about, do they have IBS? Do they have SIBO or other chronic gut issues? You also might want to look at their metabolic syndrome or autoimmune issues, because we can start to see a tendency towards that even in their gut flora. Okay. So let's get into the urinary metabolites. What are they actually looking at? And I'm going to show you a sample in just a moment for those of you who are not familiar. But number one, we're going to be looking at the quantity and the metabolism of these hormones. So we're looking at estradiol, we're looking at progesterone, testosterone, DHEA-S. We're also looking at the metabolites. We're looking at the detoxification in the adrenals. So looking at, of course, the cortisol levels, but also the pathways and those how they're doing over the morning, noon, evening, and night. What is the value to all of these? As I mentioned before, if they do have estrogen dominance, why? What is it? Is it because their estrogen levels really are elevated and high? Or is it because, maybe their progesterone is way too low in comparison, or whatever might be going on? For HRT management, and so now you're not going to use something like this on a routine basis when they're coming in for regular checkups, first of all, because as we talk about down here for limitations, they're a little bit more expensive than just getting a serum blood test. But you also don't need them necessarily just to monitor levels. However, if you are having issues, and remember, like I said, if they're not responding the way they should, or if you're treating them and they're still struggling, then you really might want to start looking at them. If they've got that HPA axis dysfunction, okay, and that's huge, especially in this population, the fatigue, the insomnia, and if there's any concern about their adrenals, you probably do want to know. And then finally, do they have a family history of these hormone sensitive cancers? All right. So what do they look like? Here's a sample Dutch. And as I mentioned before, I love these. I love showing them to people, especially, and I'm going to show you another slide in just a moment, that I actually even share with my clients who will sometimes want to come in and just talk about, oh, well, I need whatever it is, I need testosterone, or I need, estrogen, or I need progesterone. And I will often show them not only this one, this is just a sample, of course, but I'm going to show you another slide that shows all of the interconnections and how complicated hormones are. And so trying to just pluck one out and treat just one can often backfire, not only for us, but for them, because there is such a complex interconnection between them all. So if you kind of look at this, they go with a dial pattern. And just as if you've never seen one of these before, so with the Dutch, what they're looking at is these, they start with, they're all on this dial. The gold is like the high and the low, okay? The purple is postmenopausal status. The green is premenopausal status. And so you're looking at the numbers that might be for that. So for instance, if someone has a DHEAS, which we know is important for energy and motivation and just feeling really great, well, this particular one is below the star on this side. So even below a menopausal woman. So we might wonder, okay, just seeing this, not thinking anything else, might this person be struggling with energy or motivation or getting up and that sort of thing, that get up and go sort of thing. Okay. Then we get into, so this side is all of the androgens. Okay. The DHEAS, testosterone, which would be in the regular, if this person is perimenopausal, she would be okay in that level. She's not in that menopausal time. But then if you go down into testosterone, okay, we will see there are two forms of testosterone. And this is another reason it's really important to see. So with this particular person, there are two forms. One is a little bit more androgenic. So if they're going more towards the DHT side, they're going to, for the same amount of same amount of testosterone, they're going to see more of those androgenic effects. So they may have, issues with acne or feeling a little more aggressive or having issues with their hair if they have a high level and is kind of shifting over to the right, over to this more androgenic side. So in this particular example, yeah, this person is kind of on the high side with DHT. So we might, talk to them about, are they seeing those kind of symptoms? All right. So that's where I'm saying we want to make sure if we're going to give somebody something, we want to know what they're going to do with it. So if we're giving her testosterone, we want to make sure, that she's not shunting it all over here, because yeah, she'll be calling you, letting you know, hey, I don't feel great. It's like I've got too much of the testosterone. So that's one of the really good values of looking at it this way. So even if her levels aren't high, she may still have symptoms of high testosterone if she has that real shunt over to the androgenic side. Then on the other, we look at the progesterone, and she's kind of in the menopausal layer for all three. Okay. The alpha is a little bit more sedating. So, again, if she's struggling with being, really kind of drowsy and things, you might want to look at that. This particular person, it's not an issue, but that might be why. And then finally, we get into the estrogen. I'm going to go to the next slide because I have it a little bit larger, just because it's, I think it's actually maybe the most important out of these three, with the way the estrogen is being metabolized. And so we have E1, E2, and E3. Estradiol is the most prominent. Estriol is the weakest, but also the most protective. And so we see that this woman starts with all of her estrogens kind of on the high side. She's definitely not in the menopausal purple area. She's a little bit on the high side of all three. So now we kind of think, okay, well, if she's kind of high with all of these, and if we go back and on the low side with progesterone, what what symptoms might she be having? Okay. And if she's not in, if she's not in the steady state, if this is perimenopause, this might be, a 1 day event for her. However, what we're seeing is she's got a higher estrogen than she does progesterone. And so this is someone who might have symptoms of estrogen dominance. So those cloudy periods, the headaches, the weight gain, those sorts of things. That's just one thing for us to look at. Then once we have these three, they are going to metabolize into and be detoxified by in three different pathways. And it's really, they make it kind of easy for you. So the green pathway is good. We want to go down green. The red pathway, we really don't want to go down that way. And then the blue one is actually proliferation. So let's take a little run down the green pathway first. So this will go to 2-hydroxy E1, all right? And you notice she went from way up here to coming a little bit down here. So she went from this side to way over here, all right? So she's not really shunting a lot of her estrogen into this good pathway, what we're going to call the good, safe pathway. And then when we get to methylation, she's even a little bit lower. So now what we're seeing is that her methylation activity is really on the low side. And so this is someone we really want to be careful of just throwing estrogen at her, because what might happen? We might, is not going where we'd like it to go. We want as much as possible. If we're getting rid of estrogen, we want it to be going down the healthy pathway and being, excreted well. Then we look at it this way, and we look at the bad. Now, why do I say it's the bad pathway? Well, this is the one where it can make more reactive quinones. And what does that mean? If these are not detoxified, that's going to increase her risk of breast cancer and endometrial cancer as well. So we really want to make sure that as little as possible is going here in comparison to here. Okay. But if we look at it, her 2OH to 4OH is pretty low. So she's shunting way too much over here. Same thing with the other. Okay. She's really shunting too much in the proliferative as well. So if we have a choice with all of these, we really want to, before we start increasing her estrogen, just across the board, we want to make sure of two things. If this is her, her steady state right now, and not just a fluke that her progesterone's low or estrogen's high, we want to make sure that we're shunting and moving it in the right direction. Okay, so let's talk about those three highways. The 2OH is the protective clear lane. So it clears rapidly, it doesn't proliferate a lot. So to optimize it, we want to look at dim cruciferous vegetables. That's, those are the, someone's coming in the waiting room. So we want to look at dim, we want to look at cruciferous vegetables, flaxseed, and exercise and weight loss. A lot of people don't want to hear that, but this is important. Okay. Then we've got that other highway that we do not want to go down, the red one. This is the danger lane. And this is the one that's forming those DNA damaging quinones. Okay. So to minimize these, we can look at things like glutathione. That's going to help to detoxify N-acetylcholine. The methylation supports just B vitamins, B6, the B complex, B6 and B12. And then, of course, things like antioxidants. These are the things that are going to help to reverse the effects of having these higher levels of the 4-hydroxys. And then that third pathway that we were talking about, I say it's kind of sort of in the middle, but I think more proliferation, okay? And it can also be linked to the estrogen sensitive cancers. So to balance these out, fiber is wonderful for just kind of grabbing onto excess estrogen and getting it out of the system. make sure that before you give someone fiber that they're able to eliminate it, because if you give them a lot of fiber, they get bloaty and ooh, they are not going to like you. So do it slowly. Same thing with probiotics, and it will reduce that beta glucuronidase, which we're going to be talking about in just a moment. Okay. So, and this is something that we is was very much talked about, or is being very much talked about, with estrogen metabolism. So we know that estrogen is made in ovaries, adrenals, and adipose tissue. And that's why one of the reasons why when women have a lot of fatty tissue, which is very metabolically active, they tend to have more issues with higher estrogen. So all three of those are making estrogen. It goes to the liver to be detoxed, to be conjugated, and it has different conjugations. So this little, the estrogen is going to be that little tan, orangey thing, and the conjugated part is the little dot. So then it can either be excreted through the kidneys, or it goes into the gut to be excreted the other way, which is what it's supposed to do. It kind of goes here, and then and so it will go to here. In the gut, though, there are certain bacteria that will produce something that cleaves. It's going to produce that beta glucuronidase, which is going to cleave that binding protein, so it's no longer conjugated. Well, now it's not water soluble. It's not. It can't be excreted in the stool. Now it's going back into the blood and being recirculated into the liver. Okay, so now rather than excess levels of estrogen being shunted out one way or the other, they are being brought back into the liver and recirculating in our body. So we're going to see increased levels of estrogen if the beta glucuronidase levels are elevated. Okay, does that make sense? So that's the estrobolome. So if we have the estrobolome are all of those bacteria that are affecting the estrogen levels in our body. Okay, so if we have lower microbial diversity, right, we're going to have increased beta glucuronidase and glucosidase. Okay, so we're going to have increased levels of those enzymes, which means increased deconjugated estrogen, which means increased absorption, more circulating, and more tendency towards estrogen dominance. Yuck. However, if we get ourselves, so we have that good microbial diversity, if we've got the good bacteria in there, all of those things just flip around and we stay in homeostasis, which is what we want. Okay. So this is just really a recap in this way. Phase 2 detox, it should be excreted, but beta glucuronidase will cleave it, brings it back into the body, reactivates it, and that's where we get that estrogen dominance. We talked about what issues that happens if we've got that estrogen dominance. Now we've got the symptoms, the breast tenderness, the heavier periods, worsening PMS. They're going to start gaining weight, usually around the hips and thighs. That's where estrogen sits. It loves that area. Mood swings and irritability. And then, they're really not going to respond as well to progesterone alone. What's the strategy? We want to get it out. We want to support the body to get that extra estrogen out. So we can do it through just go straight to the source, calcium D-glucarate, direct inhibitor will help that, but also looking and helping the gut, giving the gut back what it needs. The lactobacillus and the bifidobacterium are two that are really, really important for this support. The fiber, as I mentioned before, be careful how you start adding it, do it slow, low and slow, and then add that. Okay. And just briefly looking at what estrogen's effects would be. If we want to be here in the middle, homeostasis, we don't want the low levels, right? Look at those things that we've got. We don't want the high levels because breast cancer, the endometrial hyperplasia and cancer, all of these things on the right. So we don't want dominance. We don't want low levels. We want to be right there, like they said, Goldilocks, not too hot, not too cold, right there where we should be at homeostasis. I'll do a quick testosterone metabolism because yes, women do need testosterone. And yes, as a matter of fact, It's one of the amazing facts, but we have more testosterone in our bodies than we do estrogen. So it's just a fact of life. We need it. We make ours. We don't have testes, so we make ours in the adrenals. And same sort of thing. If we have too much of beta glucuronidase that cleaves elevated levels of testosterone, that specifically for women can be an issue. Again, lower and higher microbial diversity, the higher, the better, the lower, you're going to have those effects. Okay. And for women specifically, those high levels, that's when we start seeing things like the hair that doesn't go away, the irregular menses. And look at this, insulin resistance and type 2 diabetes. Who would have thought that having higher levels of testosterone would affect our metabolism in that way as well? Okay. So, what is the effect of this gut health on when we're trying to treat our clients and patients with hormonal therapy? What tends to happen? Well, you just saw our microbiota will actually influence how effective our hormonal therapy is going to be. If they are dysbiotic, which if they are stressed, we now know, well, let's take a step back. If they are one of these high demand women, we know they're stressed. So that stress has a negative effect on their gut. And now we know that that negative effect on their gut has a negative effect on their hormones as well. So we really want to start customizing what we're doing also based on what's going on in their gut. Okay. So what are some of the markers that you might want to look at? One of them is, these are some of the inflammatory markers, calprotectin, secretory IgA, lactoferrin, and zonulin. A lot of us are really familiar with zonulin because that's the one that's really connected to intestinal permeability, leaky gut, that sort of thing. So you can look at these levels, and these are just like, as I mentioned, there will be differences between different labs, but they're basically, if these are high or low, what might you be looking at? So say, for instance, with the secretory IgA, if it's low, you want to support their immune system. Okay, remember that is their first line of defense when there's some sort of invader coming into the body. So we want to make sure that they've got it. We want to support it if need be. So S-bulardi, vitamin A and D, zinc, these are the things that we want to do to be able to support that immune system. But if it's high, what is it telling us? It's telling us that the body is on high alert. Okay, something's actively going on. So here you want to identify what's going on and remove that chronic infection, or whether it's a food sensitivity or whatever else it might be, so that they are, so that they can do what the body can do what it needs to do. Okay. And then there are, of course, the beneficial bacteria and the pathogenics. So the beneficials are the ones that we actually want to increase. The lactobacillus, a lot of us are very familiar with that one, but bifidobacterium as well. That's really important for our short chain fatty acid production. Critical. That's what our colonocytes are eating. They need those short chain fatty acids. Akkermansia, which is really big in all of the papers these days, how important Akkermansia is, both to gut health, but also for weight, for our metabolism. And then the last. So this is the primary butyrate producer. And we know that butyrate is one of those foods for our gut flora, and therefore for our hormonal support. Now, the ones that we want to decrease, C. diff, we definitely don't want that. The pathogenic E. coli. Remember, we've got all of these, and they're not bad in and of themselves, but when they have taken over, then they are a problem. Klebsiella and then the Candida. And so what do they look like? What is the impact of these specific pathogens? Well, increased beta glucuronidases with estrogen if you have high pathogens, resorption, and dominance. If you have low beneficials, you're not making the short chain fatty acids, you're going to be more inflamed and they're going to have more symptoms. And then finally, if you have candida overgrowth, it can actually, believe it or not, mimic estrogen and increase those dominant symptoms. Okay. So briefly, the three short chain fatty acids, three main ones, butyrate, propionate, and acetate. The butyrates are the primary food for those colonocytes. They're anti-inflammatory. Your body needs them. Propionate, think more of regulating your metabolism. So these are the ones that are going to tell your body, oh, I've had enough food. I'm good. I don't need anything else. And then finally, the acetate is your energy. So we want all three of them. We've talked about if they're high or low, what can be the problem. So how do we support them? Very clearly, fiber, probiotics, prebiotics, feeding those healthy ones. And you want to make sure before you start feeding, you're feeding the right ones. And then finally, the fermented foods as well. Okay. So with all of these testing, these are not the lab tests that are looking at estrogen, progesterone, testosterone. These are now more functionally based, and they're also more complex. So they're also more expensive. We just talked about that. So we don't want to just willy-nilly order them whenever someone comes into the office. We want to know why and what the value is that we're getting out of them. So if they're coming in, number one, estrogen dominant, despite having progesterone therapy, and we might see that they have a high beta glucuronidase, which is reactivating that estrogen. So you would see those things on their gut test, right? Maybe they've got severe menopausal symptoms and they're that bloating that we had talked about. So now we're looking at those inflammation markers as well as low short chain fatty acids. Maybe we've done, they came into our office, they changed their life, they're getting better sleep, they're eating the right stuff. We started them on some hormones and they're still struggling. Well, maybe now we want to take a peek at that. This might be, maybe there is some gut pathology going on. And so we might expect multiple abnormalities, inflammation, permeability, dysbiosis, SIBO. Oh my goodness. Maybe they do have this history of IBS, SIBO, or other issues. So we might look and see at them, see what they look like. And remember, we should know that SIBO, that a comprehensive stool test is not the first test if you're anticipating them to have SIBO. You're not going to jump right into that. There are less expensive and more precise tests that will talk about that. And then finally, if they have metabolic syndrome and perimenopause, you might look at those low commensals, especially the akkermansia. Remember, I told you we're seeing more and more how important they are for our metabolism and how they can actually help. There are some products out there that are mainly akkermansia and the butyrate support that can start changing people's metabolism, both those with type 2 diabetes and those who are not, who just tend to be a little more insulin resistant. We're going to talk a little bit, not too much, about AMH, which is the gold standard for menopause prediction. Those are the studies you can look at if you like. Mainly, when would you order this? When we're looking at if they want to get that information about their fertility. Okay. If there's early perimenopause planning, and definitely if they're less than 40 and they have amenorrhea. These are the numbers that you would look at. And why might it be superior to FSH? Well, follicle stimulating hormone, mainly because FSH, especially in perimenopause, is flipping all over the place, right? It's up, it's down, it's backwards, it's everywhere. And so on any one particular day, who knows where it's going to be, which is one of the reasons why for a POI, you have to make sure that you are measuring it twice, at least 4 to 6 weeks apart. And you're not just taking a one-shot look at a number and saying, oh, this is what's going on. Okay. So now we've got this integrated diagnostic framework. Okay. So you want to start with their assessment. Look at their age. We want to hope that, look at that being more than 45, they've got symptoms, diagnose them clinically. That's it. You don't need the tests per the study. If they are 40 to 45 and they have symptoms, you can consider the FSH and the AMH to confirm that they are in perimenopause. Okay, and that's, again, if they have symptoms and they're struggling, then yes, having that confirmation can really be a great support. Okay, but it is not necessarily, that's more an optional kind of thing. But definitely, if they are less than 40 and they have these symptoms, their menopausal symptoms, you want to do that full POI workup. Premature ovarian insufficiency. That's the FSH times 2, the E2, the AMH, anti-Mullerian hormone, TSH, and prolactin. Because remember, we want to make sure, we're not saying that we're not going to tell someone, oh, you are in early, your ovaries have shut down, you're in menopause, and it turns out that they're just severely hypothyroid or something of that sort. So we really want to make sure we're not excluding, no, actually we want to make sure that we are excluding anything that might not be POI. Then step 2, functional testing if indicated. Okay, and we're going to be doing some practice in just a bit. If they are estrogen dominant, if their serum levels are normal. Okay, so remember, estrogen dominant and their levels are, estrogen's way up here, progesterone's way down here, we can see this is why they're dominant. But if their levels are normal and they're still showing this period, why might that be? Okay. If they're not responding well, we're giving them the hormones, they're not responding well. We want to know, we can look with a Dutch, however we're looking at those hormone metabolites to see what their body is doing with them. The GI and hormone systems. We want to look at that stool test. We want to know what's going on with the beta glucuronidase. Now that you know what it's all about and what it can do to their hormones, we want to look at inflammation. We want to look at dysbiosis. We want to look at their short chain fatty acids. And then finally, with a metabolic syndrome, we also want to look to see, do they have a dysbiosis going on? Do they have very low commensals, especially as we now know, things like acromantia. Okay, that's step 2. Step 3, interpret in context. All right, so serum is going to be telling us the quantity. Dutch is telling us quality. How's it being metabolized and oxidized? Stool is telling us, of course, the gut impact. And all three, we need these layers for those who are really complex. If someone's coming in and they're really cut and dry, this is what's going on. No, of course, we're not going to waste their time and money getting tests that we don't need. But if we have those questions, then definitely we will. Okay. And then finally, we want to make sure that we're treating the root causes. So there's that sequence of care. And we want to make sure, and we look at all of these, and sometimes you got to do them pretty close to each other, or especially women who are busy, don't want to take any time out anyway. You sometimes have to go a little faster than you might want to, but you want to make sure that their gut is healed first. Because if you're giving them stuff and their gut can't take it, it's not going to work anyway. So you want to make sure you're doing that. You want to make sure that they're methylating well. Because remember that woman who was going way, she was almost going straight down that 4-hydroxy pathway. If we keep giving her more and more and more estrogen, and she's getting more and more and more down that pathway, we're just loading her up for an issue. So we want to make sure that we know what's going on with these hormones when we're treating. We want to look at dysbiosis. Do they need an antimicrobial or a prebiotic? And then finally, when all of this other stuff is great, then we want to start, and then we're able to optimize their hormones. Okay. And I told you I would show you this one before. We are definitely not going to go into this, but I show this to you. And also, this is one that I will often share with my patients and clients because, when they come in and say, I need so and so, or my friend had this and therefore I need this. And I love to show this picture because it just shows you the interconnection of all of these hormones. We've got DHEA here, we got progesterone here, testosterone here, cortisone here, the estradiol, just everything that is so interconnected. It's an orchestra, it's a symphony. And we can't just pluck one instrument out of that symphony and think that's going to be the answer to everything. That's why I love to show this to them. And the other reason is that, it shows all of the things that might increase that particular hormone or decrease that particular hormone. So it's really, it's a great tool for us to look at, but it's also a good thing for us to show, when we have someone who, specifically if they're impatient, what that might be. Okay. So now we're going into, this is now your turn. Okay. And we're going to go into 3 cases with our 3 phenotypes that we had from last time. The first one is going to be our executive. All right. So Sarah is an executive. She's a CFO. She's a high impact executive. When she's coming in, she's got hot flashes, night sweats. She's not sleeping well, 5 to 6 hours a night. And she thinks that's fine. Okay. And you're going to hear that a lot. I don't need any more than 5 or 6 hours. But now what she's noticing, what she's actually coming in about is the concern that she's having difficulty with finding words and speaking. Okay. Her short-term memory is starting to get a little bit worse, and she's starting to get more anxious before she has these high-stake meetings that she's going in. She's walking into these boardrooms and she's getting anxious. What are her unique stressors? Well, of course, she's in the C-suite. So that in and of itself is one. She's on her computer and laptop late at night. 4 to 6 drinks a week because she's going out and networking, and then irregular meals when she's traveling. Okay. And then finally, her initial snapshot, BMI is 24, BP 128/82. The cycles are irregular at 26 to 48 days. So what do we know about this woman already? Before we even look at anything else, what do we know about her? You can either come off mute or you can put it in the chat. But what do we know about her already? What are we thinking might be going on with her hormones? And I know I feel like I've been talking like a whole bunch a lot, which I have actually. Any ideas? Well, let's start with a really easy one. Let's start with an easy one. What do we think is going on with her cortisol? Do we think it's normal? Do we think she has that normal up nicely in the morning, goes down at night, and she sleeps well at night?
Her cortisol is probably really high.
it's probably like crazy, like especially in the morning, and it may just stay that way all day long. So she's probably not seeing that normal up and down that we would like to see. We're starting to see, so she's got irregular meals. We're seeing that something like that can start to affect not only her cortisol, but also her metabolism. So, that may be starting to change. She's got these hot flashes and night sweats. So we know that her estrogen is going up and down, right? That's the whole thing with hot flashes. Hot flashes doesn't mean that it's low estrogen. It means that it's variable, very variable. So she's got that. And then this whole cognitive overload. That's one of the things we start to see again when our estrogen levels are not quite where they need to be. Again, usually on the lower side, but it can also be elevated as well. So not even knowing anything. Oh, yes, and her cycles are irregular. So with this age and irregular cycles, we can essentially diagnose her with perimenopause. We don't even really need a test. So that's what we know about her without knowing anything else already. Great. So now we did, she wanted to get some labs. She wanted to know everything. So her FSH is 38, which is elevated for someone of her age. Her estradiol was 90, which is on the high end of normal. Her progesterone was 2.8, which is low, meaning she did not ovulate in this particular time. So, what does this mean clinically? Well, at this particular state, because her estrogen, this particular day when these labs were taken, her estrogen was high normal, her progesterone was low. So she's now in an estrogen dominant state. The higher FSH is that whole ovarian reserve is starting to decline, but she still has that while her progesterone is really low. Okay. Um, she wanted a Dutch test as well. So we got that as well. Her ratio, the 2 to 16 ratio, was low. Okay. So she's making a little more of that 16 that we would like. Her 4 hydroxy pathway was elevated. Again, that's the risky metabolite, very similar to the sample test that we saw. And her methylation was suboptimal capacity. So she's got more of the risky 4-OH of that metabolite, and she's not getting rid of it well. Okay, so what is that making us think? Well, she's that estrogen is going down the proliferative and risky ways. And actually, I didn't put this in, but as you had said, Katya, high cortisol awakening response, right? So she woke up and it was boom off the charts. Okay, excellent. So that chronic stress is right there, which is also sabotaging her detoxification. And then, as I mentioned, we also want to look at her stool. And so here, oh, I see there was there. Her beta glucuronidase was moderately high. Her beneficials were kind of on the low side, and she did show signs of inflammation. So what are we thinking here? Because we've got that inflammation and the cortisol and everything, and now we're thinking that the beta glucuronidase is elevated, okay, that we see. So now we're seeing estrogen is recirculating. When we put that along with her lower progesterone and the fact that she is in that risky quadrant where it's kind of decreasing, now she's in a kind of a not a great state. So we really want to make sure that we're taking care of her well. So she's got estrogen dominance, poor metabolism, and reactivating. Okay. It's not just because her hormones are going up and down. She's got the high cortisol level, she's got gut, dysfunction as well. And so we want to look at, she needs to be treated for all of this. So if we just came in and said, oh, her estrogen was fine, so we'll just give her some progesterone because it's a little bit low, might it help a little bit? But she's got all of these other things going on that we wouldn't be addressing had we not looked at these. Okay, so that's our first lady. And this is the plan we put her on. So we wanted to support her adrenals. Okay. We went with adaptogens, at least to start with, right? So adaptogens, if you're high, it's going to help you come down. If you're low, it's going to help you come up. That's why they call them adaptogens. We started with ashwagandha, and ashwagandha is like, it's amazing. It's like, I don't even know how it does what it does. But if you take it at night and you need it, it's going to help you sleep. If you take it in the morning and you need it, it's going to help you wake up. So it's an amazing thing. Rhodiola, mainly you want to take that in the morning, and that's going to help with cortisol modulation. With the metabolite shift, we started with DIM to kind of promote that 2-hydroxy pathway and reduce the 4-OH load. Methylation support, methylfolate, methyl B12, and P5P. And these you can have just in one tablet. So again, you want to make sure that we want to keep it to, if possible, 5 or less things that we're changing at once, and give them as few things as possible to do. Okay, so if you can get everything at the numbers that you want in one product, that is the best, right? Sleep and relaxation. She's got to sleep. Okay, so we talked about magnesium glycinate, which is also going to help her gut. It's also going to help her metabolic state, plus the oral micronized progesterone. Okay, oral is going to help with sleep. Topical does not help with anything as far as sleep and anxiety. And then finally, limiting the alcohol to less than 2 a week. Strict blue light, nothing for at least an hour, 2 hours is better before bed, and then really winding down. So, what kind of results did we get? Whoa, okay. Hot flashes down. Sleep duration for her, 1.5 to 2 hours of sleep was amazing. I mean, amazing. The word finding really stopped. And that, I think, out of, like I said, that's what brought her into the office, was that concern about, I can't think of what the word is. It was that brought her in. So when that started flipping back around, she just felt wonderful. Dutch markers improved, and not everyone's going to do a second Dutch, but a lot of times if they're curious, especially when the first one shows such obvious changes, they'll do something like that. And then finally, anxiety, those pre-meeting anxiety spikes just really kind of dropped as well. So that was Sarah. Our second phenotype is our elite athlete. So this is Maya, 42. She's an elite CrossFit athlete. She lifts stuff that I can't even move, okay? She presented with regular, almost absent. She was pretty much amenoretic. Post-training hot flashes, post-training, right? Severe fatigue with delayed recovery. Okay, so now she's got that, what they call DOMS, delayed onset muscle soreness. Why they have to give it a name, I don't know, but it's called DOMS. So she was getting that sleep 6 to 6.5 hours, despite being exhausted. What are her stressors? High training volume. I mean, this was her life. So she was in the gym all the time. Keeps that body fat low for competitions. And around competition time, she really cuts everything down to the bone, right? Intermittent fasting combined with heavy caffeine, because she's got to keep things going. BMI 21, which can be, as it often is in elite athletes, very, kind of steers you down the wrong path, because a lot of this is just muscle. So there's nothing on there but muscle, right? Resting heart rate, 52, not unusual. Ferritin was borderline low. So what do we see with her? We looked at her E2 was low normal, progesterone less than 1, FSH, LH, both low normal. So what are we thinking here? So now she's not cycling, right? She's anovulatory. So she's not she is not ovulating, which is why her progesterone is so low, but her E2 is also low. Okay, so now we're thinking, is it perimenopause or is it something else? And we have to think about this. When we look at this third one, FSH and LH, these are low normal. Okay, so if you've got low estrogen, what would you expect your FSH to be? High, right? You expect it to be high. So when they're both low, then we want to start thinking, okay, maybe this is coming from the hypothalamus, from the brain, rather than from the ovaries. Okay, and that's something that you will, often see in these elite athletes who are pushing themselves to the limit, not eating properly, and then they stop having menses altogether. Okay, we looked at her Dutch. Total estrogens were low, DHEAS low, cortisol flat. Okay, what are we thinking here? Adrenal exhaustion and depletion. Okay. Flatline cortisol. And I'm sorry, I'm supposed to be asking you guys this. So she is, yeah. So I'll let you kind of jump in right here, right? So she's exhausted. So what is that going to look like? We said on the other one who was really stressed, in the morning it was like up and down. But with her, if she's just worked herself to the bone. So what would her cortisol line look like? Essentially flat. I already gave it to you. So she's flat. It's like there's no bump. It's at the bottom of the thing. She has just really run herself ragged. Okay. And If she
I
continues,
have one question
yeah,
for
sure.
for a patient like this that
Hmm.
is such an athlete, right?
Hmm.
And it's like BMI might not be the best metric. Do you look at, like body fat percentage or how they're producing leptin? Because like all of those things can also have an impact
Absolutely.
on
Yes,
the results.
absolutely. And so that's if anything, her BMI probably is higher than what I had there. But
Yeah,
um, yeah, so now we're looking at, what does their muscle look like? What does their
yeah,
body fat look like? She's doesn't have much body fat.
yeah,
She is almost pure muscle, but she's also struggling to make more muscle or to maintain that muscle because she is so low at this point. Her adrenals are so low at this point, and she's not feeding herself, trying to stay in that pre-competition state. So
yeah,
those two things have really put her at a significant disadvantage. And that'll come into how we kind of talk to her about training. Okay. Good point. Good point. And then the stool analysis showed all of this low beneficials, calprotectin, and she was kind of normal. Beta glucuronidase. So with her, um, she's just not recovering well. Okay. And so she's got, as we've seen before, the relative energy deficiency in sport. So she is working out way higher than she is fueling herself. And eventually, um, she will burn herself out. So things are starting to slow down because we remember the hypothalamus is going for survival. It's going to help you. It doesn't care about your sex life. It doesn't care about all that stuff. It wants you to live. And so it's shutting things down slowly but surely. And eventually, if she doesn't change something, it's all going to shut down. So her treatment plan, number one, she had to stop the training volume. She had to bring it down. Not forever. And this is one of the discussions you need to have with them is that it doesn't have to be forever. 6 to 8 weeks, 2 to 3 months usually is enough if they're really taking care of themselves to bring themselves back up, back up to where they'd like to be. We told her she had to start having more caloric intake, especially protein, and then take that intermittent fasting window away, at least for now. It's not forever, but it is for now. Okay. Supplementation, some creatine, omega 3s, and then the DHEA support, okay, as well as methylation. And then finally, helping her to sleep a little bit better. Okay. um, what does she look like? As I mentioned, the DOMS, what a name, DOMS was restored. She actually started week 7 cycles return. So that was, again, a big thing for her. She was a little bit concerned, is this perimenopause or is it that, what else is going on? Well, with her, she was just, her whole hypothalamus was saying, you have to survive. And the only way that's going to happen is if we stop the menses. And so that's where that was coming from. Performance went up and the other things started, improving. So now she did have a cortisol spike in the morning, which is what you want. So things were going in the right direction. And usually, once patients and clients see these changes and start feeling better, then they get even more on board. Initially, they're kind of on board because they're desperate and they don't have any other choice. But when they start seeing the response, then they're like, okay, this is what I can do. And so our third client is our healthcare provider. She is an ER nurse in the trauma unit, not sleeping. She's got that nasty rotation, hot flashes, breast tenderness. We already know what's going on. Hot flashes and breast tenderness. We're thinking what's going on with her estrogen, mood, mood lability. Wow, this sounds really strange. It's labile, but yeah, lability. Post shift, carb cravings at night, and if you've ever worked in a hospital, that is the truth. Everybody's bringing out the cookies at night, and then bloating and irregular bowel movements. So what's going on specifically for her? There's the 12-hour shifts, okay? Um, she's in an ER, so and in the trauma unit. So there are, that's over and over and over. It's just slam after slam after slam of hard, fight or flight activation. And then finally, irregular meals, and she's going to the snack machine and getting stuff there because who's got time to get real food? And so that's what it looks like. Her cycles are irregular. So, in all likelihood, 47 irregular cycles, hot flashes, breast tenderness. Yeah, more likely this is perimenopause. Okay. So her labs, E2, high normal, P4, very low. So what are we going to say? High estrogen, low progesterone. What are we calling that? Estrogen dominance, right? So we're going to start seeing those pictures. High estrogen, low progesterone. We're going to see that, right? Um, and because it's very low, we're knowing that she didn't ovulate. Okay, so she's got that unopposed estrogen, right? Her Dutch test, she's got an inverted curve. So again, hers is not necessarily, or may not be due to just chronic stress, but the mere fact that she works at night. So now her whole cortisol curve is completely flipped. And she also, for whatever reason, had high 4-hydroxy metabolites. So low morning, okay, high evening, because she's shift work, right? Estrogen metabolism had an impaired methylation going down that 4-OH pathway that we really don't like. And then her beta glucuronidase was very high. So now she's got, higher levels of estrogen going down the wrong pathway and a severe dysbiosis. So she probably can't fix it either, right? So she's recirculating, butyrate low, zonulin elevated. So she's got that whole intestinal permeability, which just increases all of the risk of higher, higher levels of estrogen, more stress, more of the bad stuff. Okay. So what did we do as far as treating her? Calcium D-glucarate, again, let's put her down the right pathway if possible, support the microbiome. With her, because the dysbiosis was so severe, we're actually considering botanicals, antimicrobials. If it were one of the really nasty ones, might want to do a real antibiotic that would just kind of stay in the gut, that didn't absorb anywhere else. But that wasn't her. The circadian protocols. So wearing blue blockers even at work, and they don't have to be like the blue blockers used to be. They were like bright orange or yellow, and everybody knew what you were doing. Now they don't know. These are blue blockers. So you don't know anymore. Just wear them. It's going to protect your eyes and your brain and your hormones. Hormone support, that oral micronized progesterone at night, because it was so low, but also to help her with her sleep and cycle regulation. And then going and letting her know that it's so important to get more protein in her, good protein in her meals. Okay. And staying away from the machines. It's hard. I know. I've been there. Okay. So within 8 weeks, beta glucuronidase normalized, hot flashes down, gut systems, no bloating, sleeping better. Okay. Just really had what she needed. So the main thing was treating the gut, the estrogen, all of the hormones. And what I hope you're seeing is that we can look at things, we can either take them very, very simply, and if someone comes in and they're very clearly in perimenopause and we kind of support them and they get better, great. But if they don't, now we have options to be able to look deeper and to maybe understand a little bit better why they're seeing the symptoms that they're having, why they're having the issues that they're having. So the takeaways are these, if you're more than 45 and you've got the diagnosis, clinical is more than enough. But have a reason for why you're testing. Everybody who walks in the door does not need a Dutch or, a gut stool test or whatever it might be. look and see what they've got. Remember, most of these cases, we could kind of figure out at least a third, if not more, of what was going on just by listening to them and hearing what their symptoms were. Okay. Um, so serum is quantity, Dutch is quality, and the stool test is for that gut impact. Three complementary layers. I recommend, if they are patient enough, at least start by treating the gut first for at least a couple of weeks to a month. Um, if that beta glucuronidase is elevated, because if you start giving hormones sooner, especially if they're in the, going down the wrong pathways, you may increase that and make them even more at risk. Okay. We know these other things as well. And the main thing is functional testing is a tool. Okay. We want to use it in clinical context. Those are our pearls. Remember, just because their estradiol is normal doesn't mean it has normal metabolism. Remember, it can be going down any one of those pathways. High beta glucuronidase, which is made in the gut mainly, related to stress, related to if you think about all the things that make your gut unhealthy, those are the things that are going to increase your beta glucuronidase. Gut inflammation is going to increase those menopausal symptoms. So remember, if they are, their vasomotor symptoms, their mood, their cognition, their bloating, whatever those symptoms are, their sleep, if their gut is not healthy, it's going to get even worse. And treat the causes of what's going on. For those of us who have any functional or integrative or any kind of whole body training, we know that the symptoms are the leaves on the tree, and we want to treat the roots. We don't want to just paint those leaves green and make them look better. We want to get down into the roots and make the roots healthier. Okay. And next time, we're going to be talking about how we actually start intervening with people on a day-to-day basis. What do we tell them first thing when they come in? How do we go about the order of how we treat them? And how do we actually design a 12-week or 3-month program system? If you say program, a lot of people, they start getting this glaze over their eyes, but a system for them to start changing their life and seeing those results. Okay. And that's it for today. I'd love to open up for any questions if anyone has any.
Yeah, thank you so much for presenting today. Amy, do you have any questions?
Not at this time. I appreciate it.
Yeah.
Um, I'm gonna probably have to rewatch it to absorb more.
Okay. And
Yeah,
we'll
there was a
share
lot. I'm
the,
sorry.
yeah, we'll share
I'm
out
just
the
very new to
recording,
hormones. So
the presentation, the workbooks, all that stuff. So
yeah,
Yeah.
yeah. So
Yeah.
I appreciate it.
yeah.
Yeah, actually, and I think Katya is adding the first class that we did, right?
Yes,
The very
Yeah,
yes.
first
and I
thing.
need to
Yeah.
watch that because I missed it. So
Yeah,
that'll help too.
that will definitely
Perfect.
be a good thing. Well, cool.
Yeah,
Great.
but I appreciate it. I'm just very new at it, so I gotta get it all in there.
There's a lot. There's a lot,
Yes.
but you know what? Next week will make all of the difference because I'm going to take it
Yeah.
step by step.
Okay, and I'll rewatch the first one first.
Yeah.
So
Okay.
Perfect.
thank you.
Very cool.
All right. Well,
Absolutely.
thank you guys, and we'll be back next week on Tuesday.
Sounds good. All
Sounds
right.
good. Have a good night.
All right.
Take
Bye
Thank
bye.
care.
you.
Bye-bye.
Bye.
Oh my goodness.